So hello friends, this is our next video on pharmacology series of antimicrobials. So in this particular video we are going to discuss the next part of our protein synthesis inhibitor series. Okay, so let's start with it, and before starting the discussion please subscribe our channel if you have not subscribed yet. So next drug is your clindamycin. Okay, it belongs to group that is lincosamide. We have discussed in classification of the protein synthesis inhibitors. So lincosamide is a group which includes a drug which is known as clindamycin. Clear? Now, what are the uses of this drug? So this drug can be used in cases of protozoal infections such as malaria, pneumocystis or toxoplasma. Then it can be used for anaerobes. Basically it's a drug of choice for Prevotella GIT infection, then drug of choice for Propionibacterium acne. Third, it also decreases your toxin production. So this will be drug of choice for toxic shock syndrome, drug of choice for Clostridium tetani, botulinum perfringens. Okay, all of this. Basically, it's a drug of choice for toxin. Okay, wherever the toxin production will be there, you should administer clindamycin. So three uses mainly: antiprotozoal, then for anaerobes, and to decrease toxin production. Clear? Method of resistance, just mutation or methylation, okay, or poor permeability. These are the modes of resistance. Clear? Now moving to the next, that is side effects. So it increases the risk of Clostridium difficile. So it may lead to pseudomembranous colitis. Very important. Okay, this clindamycin increases the risk of Clostridium difficile infection. So that may lead to pseudomembranous colitis. Now coming to the next group, that is linezolid. It belongs to the group oxazolidinones. Remember this, linezolid coming under group oxazolidinones. What is the mechanism of action? So already we have discussed that it inhibits 23S subunit of 50S ribosome. Then some newer drugs have been come such as tedizolid and sutezolid. Okay, so group is oxazolidinones. It includes drugs such as linezolid, tedizolid and sutezolid. What is the pharmacokinetics? So there will be 100% oral bioavailability is associated with this drug. Okay, now moving to the next, what are the uses? So it can be used for gram-positive bacteria, for Streptococcus pneumonia. It is acting as a cidal drug, and for these all Staphylococcus aureus, Enterococcus and MDR-TB, it is working as a static drug. Clear? Now what are the side effects? So just side effect is cost, C4, chorioretinitis, optic neuritis, then SSRI-like property, and then thrombocytopenia. So these are the four side effects which are associated with your clindamycin: chorioretinitis, optic neuritis, SSRI-like property, and thrombocytopenia. Now moving to the next group, that is your streptogramins. So it is also example of cytal drug in which we use combination, that is quinonpristine and dalfopristin combination is used in the ratio of 3:7. Clear? And it is given only IV in the central line. It is effective against gram positive only. In cases of MRSA, VRSA and LRSA, we can use this streptogramins. What are the side effects associated with the streptogramin? So it can cause thrombus formation in your blood vessels, myalgia and arthalgia. Okay, so these are the side effects. So just remember, quinonpristine, dalfopristin can be used for gram positive only, and side effects such as thrombus in blood vessels and myalgia, arthalgia like side effects are associated with streptogramin. When you talk about the pharmacokinetics of this drug, it is an inhibitor of CYP3A4 enzyme. It is given in E. faecium cases but not in E. faecalis. Just remember this. Okay. Now coming to the next drug, chloramphenicol. Already we have discussed this example of broad spectrum drug. Okay, this is a broad spectrum antibiotics. It is active against gram positive, gram negative, anaerobes, atypical, all of them. Okay, it is active against all of this drug, all of these bacteria. But one there, chlamydia. Okay, so chloramphenicol is not active against chlamydia. It can be given oral or through IV route. What is the mechanism of action of chloramphenicol? That it blocks, it basically block 50S subunit. Okay, and by inhibiting this, it will inhibit peptidyl transferase enzyme also. How resistance develops against this chloramphenicol? So just know this chloramphenicol undergo enzymatic degradation by enzyme that is known as chloramphenicol acetyl transferase, that is CAT. Chloramphenicol acetyl transferase is an enzyme which degrades this chloramphenicol. Clear? This chloramphenicol. If suppose there is a increased amount of this CAT, then there will be more enzymatic degradation of this chloramphenicol. Clear? Now coming to the pharmacokinetics. So this chloramphenicol has good CSF penetration, and because of this good CSF penetration, it can be used as an empirical treatment of meningitis. Okay, especially in the cases of rickettsial meningitis. clear. Then it is also CYP inhibitor, okay, it inhibits its own metabolism also, okay, so it will start accumulating and that will cause a syndrome that is known as gray baby syndrome, okay, that causes gray baby syndrome, clear. Okay, now coming to the side effects. So the first side effect is bone marrow suppression or aplastic anemia, and this is the dose dependent reversible side effect, clear, dose dependent reversible side effect, clear. Okay, now this drug is also contraindicated in neonates because it is causing gray baby syndrome as already discussed, and this may lead to multi-organ failure and baby will turn gray. Okay, now this contraindicated pneumonia is also seen with sulfonamide because sulfonamide has increased risk, can cause chronic tears, so that's why it is also contraindicated in neonates. Now coming to the next group of drug, that is your aminoglycosides. So what is the mechanism of action of aminoglycosides? So it basically bind to 50S plus 30S both, and that will lead to IMP. We have discussed it inhibits initiation of protein synthesis, it can cause misreading of mRNA, it can cause inhibition of polysome formation. So IMP, these are the three mechanisms of action: inhibition of protein synthesis, misreading of mRNA, and inhibition of polysome formation. Now when we come to resistance, then same enzymatic degradation by AAT, APT, ANT, that is AMG, acetyl transferase, phosphoryl transferase and nucleotide transferase, clear. But these two have no amikacin and this netlimycin has no resistance, clear. Now coming to the pharmacokinetic, so it is highly polar. These aminoglycosides are highly polar, means highly water soluble, so it is not absorbed orally, and it is also not able to cross your blood-brain barrier because of the high polarity. It is not metabolized in liver, so it will be excreted unchanged in urine by glomerular filtration, and because it is depending upon kidney, so AMG required dose reduction in cases of renal failure and old age patient. Okay, so aminoglycoside dose reduction must be done in patient of renal failure and old age. This drug is also teratogenic, so can cause fetal ototoxicity, clear. Now the drugs coming from this, the first drug is streptomycin. This is drug of choice for TB, tularemia and plague. This streptomycin is drug of choice for TB, tularemia and plague, TTP. Then the drug are amikacin, capreomycin and kanamycin, and these three drugs, amikacin, capreomycin and kanamycin, will be used for MDR-TB, clear. These three are used for MDR-TB. This capreomycin does not have AMG structure, okay, it is a cyclic peptide. This capreomycin, these 2 points are important about its structure. It does not have a AMG structure and it is a cyclic peptide, this capreomycin. Now coming to the tobramycin, so tobramycin, amikacin and gentamicin, okay, it can be used for pseudomonas infection. This tobramycin is also used as topical eye drop, okay. Then this gentamicin is most common AMG combined with cell wall inhibitors, okay, such as penicillin or cephalosporin or vancomycin. These all are cell wall synthesis inhibitors. So most common aminoglycoside which are combined with your cell wall synthesis inhibitors is gentamicin because it shows good synergism, clear. Now the next drug is your paromomycin, okay, it is used for protozoal infection such as MBBS and Kala-Azar. Then spectinomycin, it is drug of choice, remember this, okay, spectinomycin will be drug of choice for resistant gonorrhea or if there is allergy to ceftriaxone. Then in these both cases, if there is allergy to ceftriaxone or there is resistant to this ceftriaxone, in both cases spectinomycin will be the drug of choice. Then coming to the topical aminoglycosides, so never given by injection because they are highly toxic, okay. The drugs are framamycin, then neomycin, okay, framamycin and neomycin. It is available as soframycin cream and it is neosporin cream, neomycin and framamycin, okay. Orally given, then there will be no absorption. It is used basically for gut sterilization, this neomycin, for hepatic encephalopathy and before surgery of GIT. So neomycin is used for gut sterilization during hepatic encephalopathy and before surgery of GIT. Now coming to the spectrum of AMG, it belongs to narrow spectrum. It is not effective against anaerobe, it is not effective for Burkholderia, it is not effective against typhoid. So trick is bad, not effective for Burkholderia, not effective against anaerobes, not effective for typhoid, because this aminoglycoside requires O2 for entry into the cell, okay, that's why it is not active in anaerobes, clear. and that's why we are saying that spectrum of AMG is narrow spectrum. Now coming to the side effects. So the first side effect is ototoxicity. There will okay, these drugs will damage hair cells, okay, and due to this ototoxicity is permanent, means ototoxicity will be permanent here, clear. Then nephrotoxicity will be there, then neuromuscular blockage will be there. Now coming to the ototoxicity, so maximum ototoxicity, vestibular toxicity is done by streptomycin, and cochleotoxic is by neomycin maximum, and amikacin, clear. So two type of ototoxicity, vestibular toxicity or cochleotoxic. So vestibular toxic when we talk about, then the streptomycin is maximum, and when we talk about cochleotoxic, then neomycin and amikacin will be the maximum. Then when we talk about least, so least will be netilmycin. Okay, least ototoxic is netilmycin. Then coming to the nephrotoxicity, so your renal cells can regenerate, so there will be reversible type of nephrotoxicity seen, and this is again maximum with neomycin and minimum with streptomycin. This is frequently asked question, okay, which aminoglycoside is least nephrotoxic. Then your neuromuscular blockage means it will block basically acetylcholine release, hence it will relax the muscle, so it is contraindicated in myasthenia gravis patient, and the most neuromuscular blocking is done by neomycin, clear. Now these are the miscellaneous protein synthase inhibitor: muprosin, fusidic acid, reptamucin and puromycin. These are the four. This muprosin basically inhibit isoleucine tRNA synthase, this fusidic acid inhibit elongation factor, reptamucin inhibit peptide transferase, and puromycin a structural analog to tRNA. So in next video we will start with the folic acid synthesis inhibitors.